Hello, everyone. My name is Dr. Mas Takashima. I'm a rhinologist and chairman of the Department of Otolaryngology, Head and Neck Surgery at the Houston Methodist Academic Institute. Today, I'll be talking about the radiofrequency ablation of the posterior nasal nerves for the treatment of chronic rhinitis and nasal congestion. All right, so here are my pertinent faculty disclosures. I was previously a strategic advisory board member of RhinAer, the creators of Clarifix. I'm currently a medical consultant for RN Medical, and I've worked together with them studying the safety and efficacy of the RhinAer device. That being said, these are my own slides that I'll be presenting today. Working with both companies, I really have had the opportunity to evaluate in detail the technologies currently present to treat the parasympathetic innervations of the nose. So my talk today will delve into treatment options for chronic rhinitis and congestion, focusing on radiofrequency, patient selection, a brief overview of the nasal parasympathetic pathway, the mechanism of RF technology, anatomy of the posterior nasal nerves utilizing cadaveric dissection, the technique of the RhinAer ablation, as well as discussion of results. So moving on to patient selection, I'm frequently asked, how do I select which patients to perform this procedure on? Great question. The bottom line is that it can be very effective in anyone with chronic rhinitis affecting their quality of life, especially those that have been refractory to medical management. Clearly, these patients are coming in as it's affecting their daily lives. Frequently, they want something that works without having to be spraying nasal sprays up their nose 4 to 6 times a day. So the framework as to who you really should consider as potential candidates are those with moderate to severe chronic rhinorrhea, because if it really were minimal, they probably wouldn't be seeing you anyway. Those with continued drainage, even after maximizing allergy immunotherapy and medications. Those with classic or non-allergic or vasomotor rhinitis symptoms that typically get worse with cold air, exercise, and eating. And even those post-fest patients with persistent uncontrolled rhinitis. So here's an example of a typical patient that I see with complaints of chronic rhinitis. This patient's a 64-year-old male with both a vasomotor and an allergic rhinitis component. He feels like he's really drowning in postnasal drainage, especially worse when lying flat. Although not necessary, I frequently get a CT scan prior to a procedure to ensure that there is no sinusitis as a component of his symptoms. His was clear. He failed maximal medical therapy, including ipratropium bromide, fluticasone, and montelukast. And in my clinic, I typically get a TNSS or a total nasal symptom score for my rhinologic patients so that I can really gauge treatment efficacy. This particular patient had a TNSS score of 10 out of 12. With the higher the number, the worse the symptoms. He underwent the RhinAer procedure with about a 70% decrease in postnasal drainage and rhinorrhea. His repeat TNSS score 8 weeks out was 4 out of 12, and he was very happy with that result. Now, I'm really not going to spend a lot of time on this busy slide, but to say that the least invasive treatment is considered to be medicinal therapy. However, you really can't discount the potential side effects, drug tolerance, and the overall cost of this long-term therapy. Prior to all of the in-office procedures that we now have, the only other option for these patients refractory to medications was to take them to the operating room for a Vidian neurectomy or a posterior nasal nerve neurectomy, which of course are invasive techniques. And in the case of the Vidian neurectomy, it can result in some exacerbations of dry eyes, facial and palate numbness. When we talk about in-office procedures, turbinate reductions, be it via cryotherapy, radiofrequency, and even submucosal reduction, have shown some improvements in rhinorrhea and nasal congestion. However, it's not targeted therapy like direct posterior nasal nerve therapy, which has been shown to be much more effective for chronic rhinitis. One advantage of the RhinAer radiofrequency of the posterior nasal nerves is that it's the same, with that same device, you can really perform a turbinate reduction or even a nasal swell body ablation at the same time. So as many of you know, RF is everywhere. The field of RF includes, but is not limited to radio waves, microwaves, visible light, Wi-Fi, X-rays. And in medicine, it really utilizes the alternating currents to cause increased ionic molecular friction, resulting in tissue heating or coagulation. An important concept is that the RF electrode is not the source of direct heat, meaning that the tip doesn't heat up. It's the friction of the vibrating molecules that results in heating of the tissues. Now, this is important when thinking about mucosal preservation, because if the device, if the tip of the device was heating the tissues by getting hot, mucosal injury will most likely result. Instead, after injecting saline into the tissues, it is the friction of that vibrating ionic molecules that we just talked about heating up, setting up a system capable of being mucosal sparing. Now, we know about traditional RF devices such as the Bovie, bipolar electrocautery. Now let's talk a little bit about temperature-controlled systems such as the RhinAer. The wattage is variable to keep the temperature at the site of the electrode at a constant 60 degrees Celsius. Here's a picture of the bipolar electrodes on the tip of this device. This device allows a controlled 5 by 7 by 2 millimeter lesion to form with the depth of the lesion at about 2 millimeters. Now keep in mind that RF is safe and proven technology. Although there aren't a lot of published data yet on the RhinAer device, radio frequency has been used in medicines now for over 75 years. So there really is a large body of clinical evidence of its efficacy and safety. So this is a picture of the generator and the RhinAer stylus. The FDA indications for use statement is that the RhinAer stylus is indicated for the destruction of soft tissues in the nasal airway, including the posterior nasal nerve region in patients with chronic rhinitis. Each lesion takes about 12 seconds to create. There is no char, no smoke. And in this day and age of communicable diseases, this is an important fact. At 60 degrees Celsius, large blood vessels are preserved and a type 2 nerve injury with axonal disruption is created. So it's not a permanent severing of that nerve. With the RhinAer device, you really can treat that full length of the turbinate if needed, as we discussed previously. You can also lateralize the turbinate with the wand, as the wand has some stiffness. The procedure itself requires 3 to 5 lesions at 12 seconds per lesion on each side. A significant advantage of RF is that I haven't seen any post-procedure ice cream headaches, some which have been very severe for my patients, which has plagued many of my patients who underwent the cryotherapy procedure. And as funny as an ice cream headache may potentially sound, I mean, we're talking about severe pain where patients are writhing on the procedure room chair just due to the significance of the pain, really wanting to even go to the wanting to go to the emergency room. And that's how severe that some of these headaches have been. And the nice thing is that the RhinAer procedure, really, you don't have that. So a huge benefit for my patients. So here are some figures illustrating the target area of the parasympathetic pathway. Activation of the parasympathetic pathway in the nose results in vasodilation and increased mucus secretions. And as you can see on this figure on this left, you have the preganglionic fibers from the greater superficial petrosal nerve joining with the deep petrosal nerve to form the Vidian nerve, which then courses through the Vidian canal into the pterygopalatine fossa to synapse with the sphenopalatine ganglion, also known as the pterygopalatine ganglion. Now from there, the posterior nasal nerves provide the parasympathetic innervations to the nose. The benefit of this procedure is that it affects the parasympathetic innervation at a post-ganglionic area, which spares the zygomatic nerve carrying the parasympathetics towards the lacrimal gland. So if we intervened between the area of the synapse to the ganglion in the preganglionic nervous structure, we would also knock out the parasympathetic innervations to the eyes, which may lead to complications related to dryness. So this technique of this blockade really involves following the course of the posterior nasal nerve with radiofrequency lesions as shown in the illustration on the right. I will also show you a video of this technique here shortly as well. Now, in addition to the main nerve branches of the posterior nasal nerve that courses out of the sphenopalatine foramina, there are also many smaller foramina of the parasympathetic nerves as it courses out through the perpendicular plate of the palatine bone inferior to the sphenopalatine foramina as shown here. So it really is important that this area is also addressed along with the sphenopalatine foramina region. And you'll get a better appreciation of what I'm talking about here in this next video. So this dissection was performed to show the anatomy of the posterior nasal nerve and the nasal palatine nerves. An incision was made, as you can see here in this picture, with a sickle knife along the posterior fontanelle, and a submucosal plane is elevated towards the posterior attachment of the middle turbinate. Now, during this dissection, you can see all the small foramina of the parasympathetic nerves just below the sphenopalatine arteries shown here. Now, near the end of this dissection, you will also see the nasal palatine nerve with its associated parasympathetic nerves coming out just behind the sphenopalatine artery as shown right there. Now, this video justifies the rationale of where the probe is placed. You really want to place the electrode head right on or just slightly above and behind the sphenopalatine foramina, which is high and just in front of the attachment of the middle turbinate as shown here. Now, I frequently see physicians placing the initial lesions too low and missing the main branches coming out of the sphenopalatine foramina. You then also want to ensure that you apply the heat to the area of the small foramina under the sphenopalatine foramen as you work your way forward, as shown here in this video. And so here we are working our way forward, really getting the small parasympathetic nerves coming out of the small little foramina and coming forward. And so once again, right there is the sphenopalatine foramina and the areas of interest that you really need to try to apply the radiofrequency energy to. So just a brief discussion on the post-operative care of these patients. So these patients really can take over-the-counter pain medications, and I place them on a nasal saline irrigation twice a day for about 2 weeks. And when I see them back on their 1-month follow-up, the mucosa is well healed without any evidence of trauma. So very simple to take care of. So this is a video of the actual RhinAer procedure being performed. As you can see, I have a Fourier elevator lateralizing the inferior turbinate. Then I'm injecting some lidocaine with epinephrine right in front of the attachment of the middle turbinate to the lateral nasal wall. You should be able to see a nice bleb, nice blanching of the tissues as you're injecting. And then here I am introducing the wand with the gel at the tip of the wand. And I am tucking it right along the attachment of the middle turbinate to the lateral nasal wall. And then once after the first lesion, I'm bringing it down, getting the small foramina. And once again, going along the top part of the inferior turbinate, as you can sort of see here. And then I'm also going to lateralize the inferior turbinate with the wand here as I also ablate the inferior turbinate. And so that's what I mean, it's got that nice rigidity. So you really can lateralize and outfracture that inferior turbinate as you are performing a inferior turbinate radiofrequency ablation. All right. So what about difficult access? Some people would say if you have a septal deviation that's blocking access to the middle meatus, that it would be a contraindication for this procedure. But let me show you this video here. So as you can see, there's the middle turbinate, and then you can see a big septal spur right there. Okay, and so people might think, oh gosh, I can't get that wand in the appropriate location. But what you can do is you can use your Fourier elevator and lateralize the inferior turbinate right here. And then once you do that, you can once again inject the tissues here in just a second, which I'll show you. So lateralizing the inferior turbinate, medializing the middle turbinate, injecting with the lidocaine with epinephrine, followed by placement of the RhinAer wand. You really want to get a good visualization of the tip of the wand because you want the electrodes to really approximate the mucosa. And so try to get the best visualization as possible. I'm going up high and creating the lesion as shown here. Okay, so just because you have a septal deviation does not mean that this procedure is contraindicated. This slide shows results from the pivotal study, which was provided by the company. Maximal results of this procedure occur in about 4 to 6 weeks in regards to improvements of the RTNSS score. Patients, however, should see an improvement in symptoms as early as 2 weeks after the procedure. There is a greater than 81% responder rate using a 30% reduction in RTNSS scores, with the average reduction in the RTNSS scale being 58%. There have been no device-related significant adverse effects. Now, these graphs show the results of the RhinAer in the allergic and non-allergic patient. As you can see, there are similar results in both categories in regards to the degree of improvement, with a decrease in the TNSS scale of 56% in the allergic population and 59% in the non-allergic population. The only other difference revealed that those with non-allergic rhinitis tended to respond quicker to therapy than the allergic population with rhinorrhea. Now, in the last couple of slides, I would like to go over some anatomical variations that may potentially lead to failure of the procedure. I've had a few patients that have failed either Clarifix or RhinAer, and then this led to a videoneurectomy. And what I realized is that the surgical videoneurectomy would typically be successful in this scenario, but why is that? Why are these patients not responding? And I really wanted to study that. And so after looking at these patients, I've learned that there are some anatomical variances which places the sphenopalatine foramina more posterior and superior than normal. And so as you can see in these pictures, I have my image guidance probe located adjacent to the posterior attachment of the middle turbinate to the lateral nasal wall. This is the area that we would typically perform the RF ablation. But in this patient who failed this procedure, image guidance tells us that we are significantly in front of the sphenopalatine foramina, or the area of interest for our procedure. So there can be, in some patients, an anatomical variation which places the sphenopalatine foramina more posterior to the posterior attachment of the middle turbinate to the lateral nasal wall. And as you can see in this photo right here, I've placed my image guidance probe posterior and superior to the posterior attachment of the middle turbinate. And the image guidance shows that this is the area of interest. So for these patients where the sphenopalatine foramina is entering into the nose a little bit more posterior, a little bit more superior to the attachment of the middle turbinate, you can identify these on a CT scan, and performing RF in the traditional area may potentially miss the posterior nasal nerves. So in conclusion, chronic rhinitis is a common problem which can now be treated with minimally invasive treatment options. RhinAer has been shown to be effective for the treatment of both rhinorrhea and nasal congestion. Now, the procedure is well tolerated by patients in the clinical setting with no ice cream headaches, which, like I mentioned before, is huge for my patients. And really, study the anatomy and consider potentially repeating the procedure in the area posterior and superior to the posterior attachment of the middle turbinate if initial treatment fails. Thank you very much. I really appreciate your attention. And of course, if you have any questions concerning the procedure, my lecture, please feel free to email me anytime, mtakashima@houstonmethodistdog.org. Thank you so much.